This video shows a hybrid approach for epicardial cardiac ablation with concomitant endocardial ablation done in a hybrid room setting. This video focuses on the surgical portions, including the Convergent approach with epicardial mapping. The first thing that is done is a standard subxyphoid window. I removed the xiphoid process to make sure that the cannula has more mobility, and I think this is an important portion of the procedure. 3 structures are identified. First that was just seen was the right inferior pulmonary vein. Then I moved the cannula to the left side of the patient, the right side of your screen. You'll see coming into view at approximately 5 o'clock is the left inferior pulmonary vein, also found as the coronary sinus, which is seen at 12 o'clock. Once these structures are identified, we proceed with epicardial mapping. I feel that this is a very valuable additional procedure that allows us for guidance of ablation and determines whether or not we have isolated the posterior wall. This adds an additional 10 to 15 minutes of the procedure, but I think it is well worth it. The limitations of the Convergent equipment are that it only really identifies the amount of energy delivered. By using epicardial mapping, we actually can know if the tissue is destroyed. I also use this technique to provide additional information for subsequent ablation. I use the CARDO system by Biosense Webster, as it is what's available at our facility and quite easy to use and can be attached to the EpiSense catheter. Our pre-ablation map is shown in the screen, and the patient has not had a previous ablation. Using this technology, magenta or purple is live tissue. Now we are ready to start ablation. I usually start at the area of the right inferior pulmonary vein. In general, I tried to take the first row as proximal as possible, and over time the pericardium loosens, so this actually becomes my middle row in the overall procedure. First, the catheter is placed. It's imperative that the black dots are directed towards the posterior atrium. The temperature in the esophageal probe is monitored before ablation starts, and the irrigation is used to cool the tissues. I slowly move from the direction of right to left between the right inferior pulmonary vein and the left inferior pulmonary vein for this, what I call first row. Seen on the screen here is typical what we see intraoperatively. The black dots can be seen, but the entire ablation catheter is not visualized. If the temperature rises by 0.5 centimeters, the ablation is stopped. We will then continuously irrigate the well until the temperature returns to baseline. For most cases, a total of 7 to 8 ablations are done per row, and I use a total of 3 overlapping rows. Most commonly, there are about 25 total ablation, plus or minus 5. As you can see here, visual cues show where the tissue has previously been ablated. As I am moving here toward the left side of the patient and the left inferior pulmonary vein. The catheter is not particularly steerable, so there will often be visual gaps between lesions, and I will often go back and finish filling in these gaps at a further time. I will then do a further posterior higher row as demonstrated here and start again from the right side to the left side. The other thing that can happen frequently is that the spine causes interference with the ablation equipment, and it will often be difficult to roll back and forth. I find kind of doing a crisscross pattern over the spine area does help achieve complete ablation. So here we are continuing at the most cephalad or posterior row towards the left side. I also use the CARDO system as I'm ablating to guide further ablation. By leaving the EpiSense catheter in place, I do measure electrograms by CARDO. If they are less than 0.2 volts, I'll move to a different spot. If not, I will apply another ablation at the exact same spot, of course making sure that there's no rise in temperature. At this point, our most cephalad row is done, and we will come out and do a third row, which is most caudad. The tissue here is often fattier, and I think a good technique and tip and trick is the following. First, I'll apply the suction catheter as seen here, and visually the tissue seems pretty fatty. However, I will look and see what the impedance is. If the impedance on the end contact ablation device is less than 110, we know energy delivery will still be pretty good. I also visually see and visually identify the coronary sinus, which we just briefly saw there, and know not to take the inferior line more than a centimeter close to this. Finally, we'll inspect our visual ablation lines from right to left and left to right to ensure that there are no significant gaps, and then we will remap our posterior wall. This again takes an additional 5 to 10 minutes on each side, but I think is well worth it. If there are any gaps, we will then go back and ablate those areas as directed by our epicardial maps. Our final map is seen here and displayed. Red is dead, so we know that tissue has been adequately ablated. There's a purple island seen at the upper left picture, which is typical of a roof line that the EP is finished from the inside. Once we are satisfied, a chest tube is placed and the incision is closed. We then move now to the left side for left pulmonary vein isolation and left atrial appendage clipping.